Hello, myself Dr. Manjunath NC. I am an assistant professor in Orthopedics department, SSIMS and RC. Today, I have come to present a topic which is slipped capital femoral epiphysis. As you can see, this is the femoral head and this is the growth plate, that is physis, and this is the proximal femur distal to the physis, neck part. There is a displacement of capital femoral epiphysis in relation to the neck. First, in any topic, we have to know what is the topic actually means. Slipped capital femoral epiphysis, it is also known as adolescent coxa vara or epiphyseal coxa vara or epiphysiolisthesis. What actually happens here is, this is a slipped capital femoral epiphysis is a misnomer. The actual mechanism is displacement of femoral neck and shaft upwards and anteriorly in relation to the epiphysis through weakened physis, while physis remains in the acetabulum. The incidence is 1 to 10 per lakh population. It is bilateral in 25% of cases. The introduction to the topic. The capital femoral epiphysis is somewhat unique. It is one of the few epiphyses in the body that is inside the joint capsule. You can observe the anatomy here with the blood supply to the femoral head and neck. This is the epiphysis, this is the physis plate, and this is the femoral neck, and the blood supply from the profunda femoris artery, which gives out branches, lateral circumflex and medial circumflex arteries, and there is artery from ligamentum teres. This is a slip through the physis. So it is very important that we know about the anatomy, that is histology of the physis. There is a reserve zone, proliferative zone, maturation zone, degenerative and provisional calcification zone. In reserve zone, there are precursor cells for the chondrocytes, and there is accumulation of the nutrients for the proliferation of the chondrocytes. And in proliferation zone, there is columnar proliferation of the chondrocytes, and then there is hypertrophic zone where maturation happens and there is degeneration of the cells, and there is calcification later. Our topic is a slipped capital femoral epiphysis. The slip occurs at the hypertrophic zone. And coming to etiology, etiology is majorly unknown, but there are some predisposing factors like age from 10 to 17 years, that is adolescent age group. There is no sex predilection, and it is more seen in frolic type of obesity. And in long, slender, rapidly growing individuals, trauma is usually trivial or usually there is no trauma. And in adipocogenital syndrome, vitamin D deficiency, there are some theories explaining the slip. One among them is hormonal theory. In our body, growth hormones, they stimulate proliferation of chondrocytes, while sex hormone inhibits the growth hormone secretion. When there is discrepancy in the ratio of growth hormone and sex hormone, when there is increase in the ratio, there will be weakening of the physis because of the increased proliferation. And one of the endocrinopathy that is most commonly seen in this condition is hypothyroidism. Then comes the mechanical factors. Usually thick periosteum in the growing age group provides a support for the physis. During the rapid growth period, there will be weakening of or stretching of the periosteum, and it becomes weak. And shearing forces will cause separation of physis easily. There is, in absolute or relative retroversion, there is increased susceptibility of slip. Increase in obliquity of proximal femoral physis slope also predisposes for the slip. The pathology, slip of epiphysis posterior, inferior, while there is shaft shift superiorly and anteriorly through proliferative zone. The deformity we can see here is varus, adduction, and external rotation of the limb. Interval of separation becomes filled with fibrous tissue and embryologic cartilage and callus. Decalcification and hypervascularity are seen at the junction of the femoral neck and epiphysis separation. After several months, the exposed portion of the neck, after the slip of the epiphysis over the neck, the exposed portion of the neck will be covered with fibrous cartilage. Femoral head firmly anchored posteriorly by fibrocartilage and thick periosteum. And we'll discuss about the classification of the slipped capillary femoral epiphysis. First, we'll go through the temporal. That means based on duration of the presentation. In acute condition, that is presentation will be less than 3 weeks. In chronic, the presentation will be more than 3 weeks. Acute and chronic. In chronic cases, when there is acute exacerbation of the symptoms and there is increased further displacement of the epiphysis, we call it acute and chronic. Based on stability, it is explained by Loader et al. The stable type, the patient will be able to bear weight. In unstable condition, the patient will not be able to bear weight. Coming to morphological classification, for the morphological classification, we need to look at the X-rays. And through the radiological views, we can classify the displacement, slip. One of the method is Wilson's method. There is linear displacement of head over the neck. The amount of displacement of the head compared to the neck is used to describe the slip, severity of the slip. And there is one more angle which is called Southwick slip angle. This angle is formed between the two lines. What are the two lines? The two lines are one line that is passing through the axis of the femur and the other line drawn perpendicular to the physis. This is the physis line and this is the perpendicular line. The angle formed between the two lines, this is called Southwick slip angle. Using these criteria, we can further classify slipped capital femoral epiphysis into pre-slip, mild slip, moderate slip, and severe slip. In pre-slip, there is just widening of the physis. There is no displacement. In mild slip, there is displacement up to 1/3 of the width of the physis, and the angle, Southwick angle, will be less than 30 degrees. In moderate slip, there will be slip of 1/3 to 2/3 of epiphyseal width, and the Southwick angle will be 30 to 60 degrees. In severe slip, as you can see here, it is up to 60 to 90 degrees, and slip will be more than 2/3 of the physis width. Then coming to clinical features, there is pre-slipping stage, acute skiffy, and chronic slipping stage. In pre-slipping stage, there is slight discomfort around groin with activity and subsides with rest. Occasional limp and stiffness are noticed. In acute skiffy, it occurs at 2 to 3 weeks after the 2 to 3 weeks of vague symptoms. Acute slip causing sudden fracture-like episode after a trivial trauma. And it has to be differentiated from Salter-Harris type 1 fracture. Then coming to chronic slip. There will be pain, increase of pain in intensity of the pain, antalgic gain due to the pain, and there is tenderness over hip, limb will be in abduction, flexion, and internal rotation. With further flexion, the thigh goes into external rotation, and knee moves towards the ipsilateral axilla. The movement of knee towards the ipsilateral axilla is called axis deviation, positive, and the external rotation of the thigh is also known as Drayman's sign. There will be adduction and external rotation deformity of the limb, as noticed. In severe cases, there will be Trendelenburg test positive. This is the clinical picture. You can see the external rotation of the limb there. Acute and chronic slip. In this stage, the prodromal symptoms will be there for more than 3 weeks with sudden increase in pain. X-ray shows significant remodeling with further acute slip. Stage of fixed deformity. There will be pain and muscle spasm. The pain and the muscle spasm that will disappear. That which was there till now will disappear when the slip starts getting fixed. There will be, but the limb will remain. External rotation, adduction, and shortening persist. Coming to complications, there are a few complications of the slip, majorly due to the obstruction to the blood flow. There will be avascular necrosis of the femoral head, chondrolysis, osteoarthritis, coxa vara, slipping of opposite hip. As we have already seen, there will be 25% of the cases who are presenting with bilateral slip. Now going to investigations. After clinical evaluation, we have to go for investigations for confirmation and assess the degree of slip. First, we can start with laboratory routine tests to rule out endocrinology pathologies. And we can use USG, ultrasonography, for early detection of joint effusion. And there we can notice epiphyseal step over femoral neck. Then comes X-ray radiograph, Röntgenogram, CT scan, and MRI. Coming to X-ray, early signs are noted on X-rays. There will be irregular widening and irregular widening of the epiphyseal line and decalcification of epiphyseal border and metaphysis. There will be decalcification noted over the borders of the epiphysis and the metaphysis. And Tretoven sign. What is Tretoven sign? In a normal hip, a line drawn tangential to the superior border of the femoral neck, it has to intersect a part of the epiphysis, lateral epiphysis. In posterior displacement, the epiphyseal line doesn't intersect. As you can see here, there is an intersection. This is the normal side. And when there is no intersection, there is slip. We can suspect the slip. This is the X-ray representation. This is the Client's line. Client's line is the line drawn along parallel to the along the superior border of the femoral neck. This is the epiphysis. When we draw the Client's line, it is not intersecting the epiphysis. So we can suspect there is a slip there. And coming to metaphyseal blanch sign of steel. In AP wave, I can explain here. In AP wave, there is crescent-shaped increased density overlaying the metaphysis. Because of the overlapping of the epiphysis over the metaphysis, there will be increased density here. It has been marked here. Then Kapner sign. Kapner sign is normally present. It is present in the inferior-medial femoral neck, overlaps the posterior wall of acetabulum. It produces a triangular radiographic density. We can see it in this image. It is shown here. There is triangular radiographic density that is present, which is absent on the affected side. Coming to lateral view. In the lateral view, we can notice the early slip in the chronic cases. There will be reactive bone formation along the superior lateral aspect of the neck. As you can see in this image, there is a reactive bone formation on the superior part of the and lateral part of the neck. And it almost forms like a pistol grip shape of deformity. And it is also known as, the hump is also known as Herndon's hump. Then we can go for CT scan. This is mainly to evaluate post-operatively the penetration of head of femur by the fixation devices that we use, that we will explain it later, which may not be well visible on the X-rays. This is also used to confirm the closure of proximal femoral epiphysis. In 3D reconstruction, to assess the residual deformity before reconstruction osteotomy. We can also get an MRI done for early detection, evaluating amount of cartilage and labrum damage. and early diagnosis of avascular necrosis of the. Now, after the investigations, now we have to plan for the treatment. And while planning the treatment, we have to have some goals, what we are trying to achieve. The goals for the treatment plan are to prevent further slippage. The patient starts with the mild form, then he progresses to moderate and severe. We have to prevent the patient from getting into further stages. That is one of the goals. And stimulate early physial closure so that the slip won't occur again. Reduction of epiphyseal displacement. Avoid complications that I have explained already, like osteonecrosis, chondrolysis, and osteoarthritis. In a patient with closed physis, the only surgical treatment in the absence of severe degenerative changes. Management options. Conservative management is usually not done. It is only done during the waiting period. During the waiting period for the surgery, the management is usually rest and traction. We have to apply this traction. Operative management, in situ pin fixation, open reduction and internal fixation with bone peg epiphysiodesis, osteotomy, and osteoplasty. Coming to conservative management, as I told, it is done during the waiting period for the surgery. Strict non-weight bearing and bed rest are advised. And longitudinal traction applied to the limb so that there is medial rotation to counteract the muscle spasm. Closed manipulation are contraindicated because closed manipulation can result in avascular necrosis complication. Then after conservative management, we move on to surgical management. Surgical management starts with in situ fixation using pinning or screw fixation. The objective is to stabilize femoral epiphysis to femoral neck and prevent further slippage. It can be used for both stable and unstable SCFE. A single large diameter central pin or screw to be placed in center of the epiphysis and perpendicular to the physis. The screw size can be 6.5 to 7.5 mm CC screw. And in unstable SCFE, 2 screws are recommended. The first screw is applied in the center as described above, and the second screw is applied in inferior and lateral compartment. The complications of the surgery are we can cause perforation of the joint, failure of physial fusion, progression of the slip in spite of the fixation, then implant failure. These are the post-op radiographic views where in this case they have used single screw, and in unstable SCFE we can use 2 screws, one in the center and one in the inferior part. In SCFE, if we suspect there is a chance of SCFE, we can also go on with the prophylactic fixation of asymptomatic hip because there are chances of SCFE on the opposite side up to 25%. The indications are high risk children with high risk of contralateral slip, young at primary diagnosis, when the diagnosis is made before 10 years of age, and there are associated endocrinological disorders and obesity. The procedures that I have told will be explained from here on. Primary upper femoral osteotomy is one of the methods. The objective is to prevent the slip and correct the pre-existing slip. There are 3 groups of osteotomies that we prefer. One goes through the femoral neck, proximal part, cuneiform osteotomy through the fracture callus, and the second one is closed wedge osteotomy at the base of the neck, and intertrochanteric osteotomy as described by Southwick and Kramer. This is the visual representation. You can see here, this is subcapital, it is called Dunn's procedure, and this is the base of neck. There are 2 methods there. One is explained by Kramer and another by Barmada. And intertrochanteric approach, where we go through the intertrochanteric area for the osteotomy. Cuneiform subcapital osteotomy. It is also known as modified Dunn's procedure. We place the patient in lateral decubitus using the approach we use is Kocher-Langenbach approach. We do trochanteric flip osteotomy, and then we do trochanteric flip osteotomy as shown in this figure. And anterior superior and posterior superior capsule is exposed and cut in Z pattern. Wedge resection of the subcapital bone directed from anterior superior. Wedge resection is directed from the anterior superior to posterior inferior direction. And it is not just important to do the surgery. Post-surgery, how the patient should be managed should also be learned. Post-surgery, we will apply the spica cast, and cast is removed at 4 weeks. Active and passive motions are begun. After 2 weeks, we will make the patient walk using crutch. At 3 to 4 months after surgery, we will advise the patient for partial weight bearing. The full weight bearing is permitted only after confirmation on the X-ray, confirmation of the union on the X-ray. This is the osteotomy of base of femoral neck. There are 2 methods, as I told already. One is explained by Kramer, it is intracapsular, and extracapsular is from Barmada. The approach used is Watson and Jones. Wedge resection of osteotomy at base of the femoral neck under the direct anterior capsular visualization is done. And then posterior retinacular vessels are safe in this method. There is green sticking of posterior cortex, which is done while osteotomy defect is closed by abducting and internally rotating the extremity. Several threaded 5 mm pins are inserted from lateral cortex across osteotomy site to capital epiphysis. This is the image representing the intra-op images. This is the osteotomy done, and it looks like this. Then there is serial pinning, multiple pinning is done to fix the osteotomized fragments. Then coming to trochanteric osteotomy. Trochanteric osteotomy, there are 2 methods, Southwick and Imauser procedure. It is used in severe slips from 30 to 70 degree of slip of Southwick angle. It is also a blind method, compensatory osteotomy. There will be varus and posterior tilt correction in this method. Osteotomy performed at level of lesser trochanter. Proximal segment assumes adducted, external rotated, and hyperextended position. This is a procedural picture. There is osteotomy being done here after the measurement of the angle that is required for the particular patient, and the proximal and distal fragments are fixed using the angled condylar blade of 95 degree. Moving on to next method, that is open reduction and fixation through epiphysiodesis. In severe slips where percutaneous pinning is not feasible, Smith-Peterson approach is used, and H shape of capsular incision is done. Using a 1 centimeter reamer, we'll create a tunnel across the physis. As you can see here, we go through the neck using a 1 centimeter reamer. We'll create a tunnel, and then we'll put a peg of bone. This bone peg is taken usually from the iliac crest. Then it is inserted into the physis across the drill hole. This is the epiphysiodesis procedure. And there is osteoplasty, explained by Heyman and Herndon. Based on anterior superior bony prominence formed in severely displaced epiphysis, exposure is similar to epiphysiodesis. The bony prominence is shaved off, the bony prominence which we showed during the X-ray description. And then coming to treatment of unstable SCFE, which is the management is done within 24 hours of the onset of symptom, and if this is not possible, it should be delayed to more than 72 hours. If reduction is to be performed, it should be done with great care, and one should avoid forceful overcorrection. It will cause the AVN of hip. Instead, a deformity of 30 degrees is also acceptable. If possible, we can fix it with two screws. Coming to treatment of healed SCFE. In absence of treatment, posterior inferior displacement of femoral head is seen, resulting in femoroacetabular impingement. It can be corrected using osteochondroplasty, reorientation, proximal femoral osteotomy, periacetabular osteotomy. Thank you.